Hello everyone, my name is Jen Nolan and on behalf of Musculoskeletal Australia, I'd like to warmly welcome you to our webinar this evening on the diagnosis and lifestyle management of osteoarthritis of the hip and knee. I'd like to begin, however, by acknowledging the traditional custodians of the land from which we are broadcasting, the Bunurong people of the Kulin Nation, and pay my respects to their elders past, present and emerging. Tonight's webinar is the fifth in our 2023 series. We have 2 webinars remaining for the year covering the condition of neck pain, as well as the topic of medicinal cannabis. If you haven't registered for these individual webinars or for the series, you can still do so via our website. We'll also be running our 2023 Coadlo Community Lecture on the 31st of October on the topic of back pain, and will automatically register all our webinar registrants for this free online lecture. If you haven't previously viewed Musculoskeletal Australia's website, I strongly suggest you do so. We have our online shop as well as a wide range of services, videos, recordings of our previous webinars, tools and services, including our National Arthritis and Back Pain Plus helpline that is available via email and phone on 1800 263 265. Our presenter for this evening is Professor Rana Hinman. Rana is a research physiotherapist and Deputy Director of the Centre for Health, Exercise and Sports Medicine at the University of Melbourne. She is a Fellow of the Australian Academy of Health and Medical Sciences and a current National Medical Research Council Senior Research Fellow. Rana's research is centred on clinical trials of lifestyle management for hip and knee osteoarthritis, in particular, exercise, rehabilitation, and biomechanical treatments. Her research has a strong focus on methods to increase patient access to care, including telehealth and digital health strategies. We're extremely grateful to Rana for presenting this evening's webinar, and without further ado, I'll hand proceedings over to her. Thanks very much, Rana.
Thanks very much for that introduction, Jen, and I'm really pleased to be here speaking with everybody tonight. This slide gives you a brief idea of what I'm going to talk about. What is osteoarthritis, or OA as I'll call it during this presentation? How do I know if I have hip or knee OA? And what can I do to manage hip or knee OA myself? A couple of disclosures just to let everybody know that my salary is partially supported by the NHMRC. And I also receive grant funding for a range of research projects from a number of bodies that you can see there on the slide. And I'm also on the editorial board of the Journal of Physiotherapy. So let's start with what is OA? Osteoarthritis used to be considered, and in fact, many people still think of it inappropriately, that it's just a condition that affects cartilage. Well, OA is more than that. It's actually the most common form of arthritis, and it's a condition that can affect any movable joint in the body. And it does affect cartilage, but it affects more than that. So osteoarthritis results when the tissues break down and we start to see abnormal changes at the cellular level within the joint. And contrary to what a lot of people think, there's actually a repair process that happens naturally in the body in response to osteoarthritis. But what happens is when the repair processes can't keep up with these abnormal changes, that we start to see the signs and symptoms of osteoarthritis, and that's the end result. And so, yes, it is characterised by some changes to the cartilage, but it's more than that, as I've said. There's changes within the whole joint that can include reshaping of the bone, lumps, or what you might see called as osteophytes on an X-ray report. We can see inflammation of the joint and overall loss of joint function. And this leads to pain, stiffness, and loss of movement in the joint. It's important to note that osteoarthritis is not the same as osteoporosis, so people can often get confused by those things. Osteoporosis is a condition when the bones become more weaker and less dense and at more risk of breaking. So if a friend tells you that they've got osteo, it may not be osteoarthritis, it may be osteoporosis. So just to be aware of those two conditions. Now, this is a bit of a slide that really tells you how or what are the factors that lead to osteoarthritis? What we see are a number of risk factors, and some of them you can't, really predispose a person to OA. And those are factors such as increasing age. Some people have a genetic predisposition, and some of those factors are systemic, such as obesity. We know that people who have a systemic condition such as obesity will be more at risk or more predisposed to OA. There's also some risk factors that can influence your joint biomechanics at the knee or the hip and make it more prone to having OA. And these can be a history of injury. So that's particularly a problem at the knee joint. So people who've had a past meniscal injury or a ligament injury. Overload of the joint, which may often happen with occupations or jobs that need lots of repetitive bending or kneeling, carrying heavy weights, or instability at the joint. And what these risk factors do is they set off those biochemical pathways that lead to those cellular changes that ultimately result in joint osteoarthritis. And no matter what the joint is that's affected, we see these common symptoms at the end, which is disability, pain, and psychological distress, which is the end result of OA. But it's also important to note that there's other factors that I've highlighted here in blue that also influence the amount of or the severity of disability and pain experienced. And these factors in blue, such as psychosocial factors, comorbidities. So by comorbidities, I mean other health conditions that occur in a person alongside their osteoarthritis. Having these sorts of issues can also magnify the amount of pain and disability experienced. And it's important to note that, because if we can address some of these other comorbid health conditions or other psychological factors such as stress or anxiety, we can also help to manage the pain and disability that results from OA. Now, osteoarthritis is a big problem, and this is a bit of a busy graph. It's there really for those of you who are interested in a graph, you can have a look at that, but I've drawn out the key points here. What are the key messages that this graph shows? Well, it shows that in 2019, almost 530 million people across the world had osteoarthritis. That's a really huge number. And so it's not surprising that hip and knee osteoarthritis is one of the main contributors to disability in people across the globe. When we're thinking about OA, the knee joint is the most commonly affected joint, and that's the blue bars that you see in the graph here. Whereas you see the pink, which represents hip OA, is much smaller in comparison. So really, knee OA is a much bigger problem, but that's not in terms of the number of cases of people who are affected. We also see that 73% of people with OA are typically middle-aged or 55 years and older, and 60% or so are female. Now, as I already alluded to at the beginning, osteoarthritis really is much more than just a disorder affecting the cartilage. So we really recognise it now as being a complex disorder that has biological factors associated with it. So those are things such as the joint damage I've already talked about, muscle dysfunction, so particularly muscle weakness occurs, changes in the biomechanics of the joint, inflammation, laxity, and even somatosensory abnormalities. But we also know that there are psychological aspects to the condition as well, where people have reduced confidence in their joint, in it being able to do the things that they need it to do. It can affect health beliefs, lead to feelings of helplessness, depression, poor coping, stress, anxiety, and pain catastrophizing as well. And we also know that it can have socioeconomic impacts, and socioeconomic factors can equally impact on how osteoarthritis affects a person. And by socioeconomic factors, I mean the amount of social support a person has, the quality of the relationships that they have and their family environment, financial factors. Having osteoarthritis can impact whether somebody can participate in the workforce, but equally financial factors can limit the amount and the type of healthcare access a person might be able to to tap into. It can lead to work stress and obviously those other vocational aspects as well. So it really is a complex condition that affects more than the joint. So we really do see osteoarthritis as a whole person condition. As I already alluded to, what's really important is that most people with osteoarthritis will have at least one other chronic medical condition. And these often include conditions such as hypertension, lipid disorders, back pain is really common, thyroid conditions, and depression is also really common. And up to a quarter of people may actually have 3 or more other chronic conditions. And so it's not surprising that people with osteoarthritis may also be at increased risk of mortality because of the cardiovascular disease that's often associated with OA. But this, it's really important to note this, because if you have other health conditions, by managing and treating those other health conditions as optimally as possible, can also have real benefits for how your osteoarthritis impacts you as well. How do I know if I have hip or knee osteoarthritis? Well, one thing we know is that OA varies really widely and wildly in how it presents clinically. So we can see young people with the condition, we see men and we see women, we see people who are still working, people who are retired. And so it really differs from person to person, but it can also differ within a person who has osteoarthritis at different joints. So someone might have X-ray changes of osteoarthritis, for example, at the knee and the hip, but no hip pain at all, whereas having lots of knee pain. So presentation is really variable. There's a lot of common signs and symptoms, though, that are typically the sorts of things that will start to cue in a health professional that you might have osteoarthritis. And that's joint pain that's related to using the joint, what we often call mechanical joint pain. So pain that might get a bit worse as you do more, as you walk, as you load your knee or hip joint, and pain that often gets better with rest. And so that's why we often see if there's any joint stiffness in the morning, it's often quite short-lived, as opposed to other types of arthritis that have a much more inflammatory component, where we often find that pain and stiffness might get worse as a person rests. Osteoarthritis is often associated with feelings of giving way or buckling, so that can be particularly at the knee joint. Impaired physical function, so a person finds that they just can't do the sorts of things that they wanted to do before. And when we're thinking about hip and knee OA, it's often things that involve walking, climbing stairs, going downstairs, perhaps getting in and out of the car or in and out of a chair. Bony enlargement, tenderness, and signs of swelling are often features, and often limited range of motion or feelings of stiffness or loss of flexibility, if you like. And some people will complain of instability in the joint, which will often be what's related to those feelings of giving way or buckling that I talked about. The most common reasons for a person with OA to go and see a healthcare professional is usually pain and difficulties with physical function, just not being able to do the things that you wanted to do anymore. And what we now know, in the past, we used to rely a lot on imaging and X-rays as the main reason or the main method for diagnosing osteoarthritis. But what we now know, and there's lots of research to show that really we can fairly confidently diagnose OA in any person who's aged 45 and over, who reports hip or knee joint pain when they use their joint, so with activity, has no or limited joint stiffness in the morning. So I sort of use that 30-minute rule as a marker to anything less than 30 minutes is often a sign of osteoarthritis, and have no other history that could suggest you have another health problem that's causing your joint problem. And as I've already talked about, with osteoarthritis, the joint stiffness tends to get a bit better as in the morning once you get up out of bed, start moving and warming up in the morning. And so if joint stiffness tends to last for a longer time after you rest or wake up, it might be a sign that you have a different type of a different sign of arthritis, perhaps such as rheumatoid arthritis. As I said, X-rays are not really needed for a diagnosis in most cases. And in fact, X-rays and other imaging are really not helpful at all for a clinician in deciding what condition you have and what is going to be the best course of action. And there's a number of reasons for this. One is because the changes that we see on X-ray aren't well related to symptoms. We can see patients who have lots of X-ray changes but actually have no pain, and vice versa. People who have really mild changes on X-ray but quite severe pain. So those changes on X-ray really don't help us in formulating a treatment plan. As I said, X-ray changes don't help predict what type of treatment will be best for an individual or how well that person will respond to different treatments. And in fact, dwelling on X-ray changes and emphasizing X-ray changes can actually lead to feelings of despair and hopelessness for a person. And then that can really have negative consequences for how open you are to trying different things and engaging with lifestyle treatments. And this is some often people are a bit skeptical when we say, you know, X-ray changes aren't a good indicator. And I wanted to put up some evidence here, hopefully so I can convince everybody out there. And this is data from a study of 115 people who were adults aged between 25 and 73, average age of 44, but quite a big age range. All of them had no knee pain. So they were asymptomatic, no history of knee injury, no history of knee surgery. They all had MRIs of both of their knee joints. And when those MRIs were evaluated, 97% of knees had an abnormality in at least one knee structure. 30% had a meniscal or a cartilage tear. 18% had other problems with the meniscus. 52% had changes in the bone marrow edema. 46% had abnormalities in muscle tendon, and another 38% had abnormalities in the ligament. And this is in people with no knee pain. So this is one reason why we don't rely on X-rays to decide if someone has osteoarthritis or not. When are X-rays and images appropriate? Really only for a doctor to exclude another condition that might be causing hip or knee joint problems, or when a person has a really unusual clinical presentation of symptoms that really don't look typical to how osteoarthritis might present. An MRI, in fact, is really only useful if only other rare conditions are suspected. If we think about blood tests, there's no blood test that can diagnose osteoarthritis, but sometimes blood tests might be helpful in ruling out a diagnosis for another condition where blood tests may be helpful, such as rheumatoid arthritis or gout. So thinking about risk factors for osteoarthritis, which there's a number of risk factors that can contribute to the symptoms of osteoarthritis, and some of them can't be changed. And those are the ones that you see there on the left in the blue box. Having had a past knee joint injury, genetics, being female, the natural shape of your joint and your age, we can't change those. But the factors in that orange box to the right, you can control and change. And we know these risk factors influence how severely osteoarthritis will impact a person. So being inactive or having a sedentary lifestyle, being overweight, having weaker muscles around your knee or hip joint, doing a job that involves lots of heavy physical work. We can think of strategies and ways to perhaps reduce that load on joints, and that might help mitigate how much impact osteoarthritis can have on your life. Having a poor diet, risk of future joint injuries. So always trying to prevent future joint injuries, even if you maybe already have some low-level symptoms of osteoarthritis, preventing it getting worse. So that leads nicely into what can I do to manage hip and knee osteoarthritis myself? And so the focus of this talk is on what you can do yourself. And we've got lots of guidelines out there that really we rely on as clinicians and are based on really strong quality research evidence to help guide doctors and allied health professionals about what we should be doing to manage hip and knee OA. And this flow chart really here describes that to you. And the backbone management for knee and hip osteoarthritis is lifestyle management, where there's strong recommendations for education and information about the disease and reassurance about prognosis, recommendations for land-based exercise and weight management if a person is overweight, so aiming for weight loss. And only then do we build upon these strategies with other types of adjunctive management, such as anti-inflammatory drugs, other types of physiotherapy that might have a place, such as massage or manipulation, and failing those optional adjuncts, then moving on to intra-articular injections of a corticosteroid, for example. And finally, surgical management is really only advocated for a minority of people when all of these non-surgical management options have failed. So if we think about what the backbone of management is, being education and information about OA, exercise and weight management, I want to talk now a little bit about these three areas, hopefully to perhaps give you some food for thought for how you might help you manage your condition. And obviously coming to a webinar like this is one way of getting education and information, because so much about giving and providing education information is actually myth busting and correcting those incorrect beliefs that many people will often have. And I'm going to go through a couple now. So people often think that pain from osteoarthritis is because the cartilage is worn down. And so therefore, if that worn down cartilage is removed or replaced, the pain will go away. Well, we actually know that that's not true. And that's because there are no nerves in the cartilage. And so we know that pain arises from multiple structures in and around the joint, and may be exacerbated by factors not related to the joint, factors such as mood, stress, and poor sleep. Lots of people think that exercise will cause more damage inside the knee or hip joint. We also know that that's not true. There's plenty of research to show that that's not the case. And we know that actually research shows that exercise and joint load is actually beneficial for most people and will help reduce symptoms of osteoarthritis over the short, medium, and longer term. A lot of people think that pain from osteoarthritis will only get worse with time. This is not true either. Most people do not get worse. And in fact, what we tend to see is really that symptoms tend to flare up, like in a cyclical nature, if you like, where you might get a flare up, but then they settle down again and flare up. And often what happens is people only remember when things are worse, and so tend to think things are really bad, they're always bad. In fact, that's not the case. People often may think that joint replacement surgery is necessary or inevitable. And this is also not true, because most people will not need a joint replacement. And in fact, some people who go on to have a joint replacement are not happy with the results because their pain may not be completely relieved. Again, this is a bit of a busy graph. I don't want you to focus too much on it, but I just wanted to provide some evidence to support some of those statements that I've just said. So what this graph shows you on the side over here, hopefully you can see my arrow. This is pain score, where pain, the higher number means more pain. So higher up the graph, worse pain. Across the bottom is time. So time for follow-up, going out to 72 months. This is a study of people with painful knees with X-ray changes of osteoarthritis. So 1,753 knees, if you like. And the researchers followed up their pain over time, over 6 years, and plotted it across time, as you can see here. And what you can see is that there was very little change in pain over 6 years in all of these subgroups of people. Only 11% of these people went on to have a knee replacement over 6 years. And in fact, if you have a look here, you can see that the vast majority of people, over 70% of people actually had no pain, mild or low levels of pain. So actually minority had moderate or severe pain. So I put this here as data to reassure people not to think the worst, that pain is going to get worse in the future. So People, and it's great that we have the internet. People often may seek information from a healthcare professional, but often there's a lot of sources out there where you can seek information on your own, which is something that people should do. Try and look for trustworthy information, though, to make sure that what you're reading is the best and the most up-to-date information. So these are just some tips here. So make sure that the information you're getting is from a credible source, such as from Musculoskeletal Australia. Check the information is current. Web pages should have details about when information was updated. Research evidence changes all the time. And a website that was last updated in 2010 is going to be really out of date and quite possibly contain information that's old-fashioned or in fact wrong. Make sure that the information is unbiased. So look at who is providing the information, and if it's coming from a company or someone who might have a vested interest in selling you a product or a service, the information may be biased or may even be inaccurate. And one way to check to see if information is evidence-based is to look for references or citations to medical research that back up the claims in that website. Some websites might use this HON code seal of approval, if you like, which is really a system of verifying that a website provides high quality and unbiased health information. We've created at University of Melbourne, based on our research, just pointing this out to people here, we've created a free 4-week course about hip and knee osteoarthritis that you may want to go and take a look at to get more information about OA and how to manage it. And you can see that we've had, it's been developed based on research evidence, and you can see lots of really positive reviews from lots of users on the website. And as I said, it's free. So that's there. I'll provide a link for that at the end of my talk. Let's talk a little bit now about exercise and physical activity. And some of you might actually be familiar with this vicious cycle of pain and physical activity that's on the screen, that when you have pain in a joint, it might not even be your knee or hip, it could be your back. It prompts you want to do less. Doing less actually can lead to problems such as muscle weakness, which leads to a less stable joint. It can lead to poorer sleep. It can lead to worries and fears because you've got pain and decreased activity and stress, and all of that then can exacerbate your pain, which then feeds more into a cycle of inactivity. We know this is a real problem in osteoarthritis, and there's lots and lots of research evidence and clinical trials that have shown exercise and physical activity is beneficial to people with osteoarthritis. And there's lots of benefits that you can see on the right-hand side of this slide. The benefits can be physical, so we can see improvements in joint pain. Usually not the day that you start exercising, usually a few weeks. You've got to stick with it for a while to get the benefits of exercise. Improvements in muscle strength, improvements in joint fitness, in joint stiffness and flexibility. These all translate into improved physical function and ability to do daily activities, walk, climb stairs, participate in those meaningful activities that people want to do. We also know that exercise leads to emotional well-being benefits as well, with improvements in mood, reductions in fear of movement and fear that you're harming your joint, and that leads to improved confidence and self-efficacy in the knee joint or the hip joint as well. And we also know there's lots of social well-being benefits as well, with encouraging social participation and improvements in ability to care for others. Oops, sorry, there we go. There's lots of what type of exercise to do. So this is a question that people often ask. Clinicians ask it and people with OA ask it. Well, the good news is there's no one real clear winner of any type of exercise over another. Any exercise is going to help. And so this slide really just shows you the 5 main groups of exercise that you can think about. Aerobic exercise is exercise such as walking or cycling. And if you're It can help with weight management, and it can also help with improving physical function. You want to consider low impact variations of that though, probably, because higher impact variations such as running might exacerbate pain a little more. Resistance exercise is strength training. So that's where you're looking to improve the strength of key lower limb muscle groups. So particularly the knee joint, quadriceps muscles, but hamstrings, hip muscles are important, but also the calf. And these types of exercises can be particularly helpful for not only improving muscle strength, but researchers also suggest that they can also be helpful with mental health and depressive symptoms as well. Flexibility exercises help improve joint range of motion and muscle pliability. So think of stretching programs. Not a lot of research to show that it might improve pain though. So it's really more about if you're wanting to improve joint range of motion. Neuromotor exercises are when we do exercises in weight-bearing positions that are using all of the lower limb muscles and nerves in a functional way. So think about balance or coordination exercises. And these can be particularly helpful for people who do feel a bit unsteady or not confident with their balance, or maybe having a history of falls. And the final group there is mind-body exercise. So this is exercise like yoga or Tai Chi, that it targets strength, balance, and flexibility, but also the mind-body connection as well. So often include elements of meditation as well. These types of exercises are often done as group classes. So if you're thinking that group exercise is something that might interest you, well, perhaps yoga or Tai Chi might be something that you want to think about. Now, exercise is generally safe for most people with osteoarthritis, but there's some key questions that you can ask yourself. These are the questions that I've got on the slide there that might indicate if you're at a bit more risk, you might be at a little bit more risk with exercise, and so therefore want to go and see your doctor first, or get advice from an allied health professional about what exercise program will be best for you. So these are for people who may have had a heart condition or suffered a stroke in the past, perhaps people who've experienced chest pain during physical exertion, dizziness, loss of balance or feeling faint, asthma attacks, people who have trouble controlling blood sugar, or any other special health condition that you think might impact your ability to exercise. It's a good idea to make sure you see a healthcare professional when starting an exercise program, rather than prescribing exercise yourself or just starting off a program without any healthcare supervision. If we think about physical activity guidelines for people with chronic conditions, the World Health Organization recommends at least 150 to 300 minutes of moderate intensity physical activity. Now, moderate intensity means that's exercise when you're breathing harder than normal, but you can still speak in sentences. They also recommend strength exercise at least 2 days per week and limiting the amount of time being sedentary. Now, these recommendations are there because that's what's good there for good health, and they can feel really daunting for people with osteoarthritis when you look at that and go, my goodness, 150 to 300 minutes of activity, that's impossible for me with my sore joints. What we do know, there's lots of research that shows it's okay to do physical activity in bouts as small as 10 minutes of activity, even if that's only 10 minutes of activity each day. And what we're now starting to see with research that's coming out in people with knee osteoarthritis, as little as 45 minutes of this sort of activity each week can improve your physical function. So the message here is as much as you can, but even little bits will help. So I think that the key message is to set a goal that's realistic and achievable for you. What about with strengthening exercise? How can I strengthen muscles? Well, you can do this by using your body weight. So you don't necessarily need equipment or need to go to a gym. You can go to a gym if that's something that you enjoy, and that's what you see there in the free weight picture, or with resistance machines, though some people might have resistance machines at home. You can also use elastic bands or cuff weights that attach around the ankle to provide resistance. Strengthening exercises, you should do at least 2 days per week to get benefit and to help build up your muscle strength. And what's recommended is to do 1 to 3 sets with about 8 to 12 repetitions at each time. But you might want to do a little bit less when you're first beginning, or if you're an older person, until you see how you go, and then you can progress that program over time. And the way that you progress a strengthening program is to gradually make it more challenging by increasing the frequency, the intensity, or the amount of exercise. But if you're feeling uncertain how to do this, you should think about consulting a healthcare professional to help get you started on a program that's right for you. What about aerobic exercise? There's lots of different types of aerobic exercise, and it's really about finding the type of exercise that really interests you and something that's feasible for you, and something that you think ideally that you can enjoy, as well as do something that's for the good of your health. So it might be walking, cycling, swimming. It might be participating in a sport such as tennis or golf. Aerobic exercise should be ideally done 3 days per week. As I talked about earlier, ideally it should be moderate intensity. So working at a level where you're breathing harder than normal, but you can still speak in sentences. And as we've already talked about the time amounts, but remembering that you can do bouts of at least 10 minutes, building up over time as you build up your stamina. So sometimes it's quite daunting knowing how to get started with exercise and physical activity, particularly if you haven't been involved in exercise for a while. And I always think walking is a really good way to start. It doesn't cost anything. Most people are in an environment, hopefully in a neighborhood where walking is where it's a good location for walking. Although I know some, maybe you live on a hill, and it might be that, you know, walking up and down hills is not your cup of tea, and you might need to drive to a flatter area to undertake a walking program. But you might have heard about steps per day, and it's a nice way of setting a goal, particularly to start off small and build up. And what we do know is that from lots of health research, that as few as 6,000 to 8,000 steps per day can actually reduce the risk of mortality. Often what's been bandied around has been that 10,000 steps per day, but there's actually no evidence behind that. And if we look at research evidence, it's actually a much more achievable goal of 6,000 to 8,000 steps if you want to actually improve how long or reduce your risk of death from other health conditions. In people with knee osteoarthritis, there's research that shows if you can walk at least 6,000 steps per day, this will protect you against having more physical disability in the future. And for every extra 1,000 steps per day you can do, it reduces your risk by a further 16 to 18%. So it's a really nice way to start, I think. And you can measure steps per day quite easily. Many of you have probably got access to these sorts of tools and devices. You can get, if you can get wearable wrist-worn activity trackers, such as, you know, a Fitbit. There's expensive versions, there's cheap versions. They'll count your steps per day. You can get a pedometer, which is a little cheap device that you can clip onto your belt to measure your steps. If you don't want to do that, many people who've got a smartphone, the accelerometer within the smartphone, as long as you carry it on your body, in a pocket, in a bag, that will measure your steps per day as well. So there's lots of health apps that you can use to track that as well. And of course, there's smart watches as well. So good idea to think about it and measuring it, because often people might overestimate actually how active they are. I often we hear in our research people saying, "Oh, I'm active enough, I don't need to do any more." But if you actually measure your steps per day, you might actually be surprised that it's not as much as you think. Of course, there's lots of health professionals who out there that you can see. You might have some regular health professionals that you see that can help you get started. In particular, in thinking about an exercise or activity program, a physiotherapist or an exercise physiologist can really help you with getting started and helping you how to choose the best program that's right for you. We've created a self-directed web-based exercise program for knee osteoarthritis that doesn't require you to see a clinician. This is free. It's called My Knee Exercise, and it takes people through a 6-month knee strengthening program. It has a range of educational information. It gives you some tips for increasing your physical activity, and includes some tools for monitoring and logging and recording your activity as well. So we've, that on the left there, that just shows you an example of some of the exercises and the instructions that are there. And we've tested this in a clinical trial in 206 people with knee osteoarthritis, and showed that you can see there in that data that pain was improved and function was improved in 72% of the people who accessed this website. Pain was improved in 72% of them, and function was improved in 68% of those same people. And that was much higher than people who compared to the group that just accessed some web-based information alone without this strengthening exercise program. We've also developed recently and tested in a trial a yoga program as well. So if you think that you might be interested in trying yoga yourself from home, this is being developed specifically for people with hip or knee osteoarthritis. And it's a 12-week program that takes you through recorded yoga classes that are led by a physiotherapist and yoga instructor. And again, we tested this program in a clinical trial and showed that pain and function were improved more in the people who went through this yoga program at home from the comfort of their own home compared to the control group. Last couple of points I wanted to touch on is weight management. So we, for people who are overweight, losing weight can actually improve knee OA symptoms. Now, there's not really any evidence, or there's not very much evidence about how weight management will affect the hip. So what I'm talking about now is probably a lot more relevant for people with knee osteoarthritis. And guidelines recommend that people should aim for 5 to 10% of weight loss to get benefit in their knee symptoms. And it may also reduce the need for knee replacement surgery in the future. Now, it's also important to remember that for people who may have osteoarthritis now, but are of a healthy body weight, it's just as important to maintain a healthy weight range going into the future, so that the weight gain doesn't start to exacerbate symptoms of OA. Because obviously higher body weight does put more load on the joint and changes joint mechanics. It can also contribute to increasing inflammation throughout the body, which can contribute to symptoms as well. Getting started with weight management can be really tricky and challenging, and it might be that you want to focus simply on some personal lifestyle changes, so thinking about your own healthy eating and physical activity. Some people like a bit more support and like to go for a more structured program, so using a more structured weight loss program or product. So, you know, thinking of something like Light and Easy, for example, where a lot of the work is done. Sometimes these can be costly though. Others might like to start by getting guidance from a health professional for advice about how to do this. So it's really important that you think about your weight loss goals and choose an approach that's feasible and sustainable for you. And one simple way is really to think about eat healthy, balanced meals and portion sizes. One of the comments that we hear a lot from our research participants is they're really quite surprised about what a healthy portion size is, and realise that one of the really simple things that they'd been doing wrong is really overeating or eating portion sizes that are just bigger than what's recommended by the Australian dietary guidelines. So that can be a helpful starting point. And again, if we think about the kinds of healthcare professionals that you might want to think about, a good starting point here is seeing your general practitioner or a dietitian, who can really be the ones to really help you get started with a weight loss program. Now, I'm going, just before we break for questions, I just want to point out that we, on our centre's website, we have lots of patient resources and consumer resources that are freely available there. And I mentioned earlier, if you've got your mobile phone there, you can use your camera to take to look at some of these QR codes, but these will take you direct to our website for our My Knee exercise, which is the self-directed exercise program for OA, the joint yoga program. We also have an app that is designed to help you stick to your exercise program, so you can actually log how frequently you exercise, and it gives you tips to continuing with your exercise. And the bottom one is that educational course that I talked about, taking control of OA. So I'm going to leave it there, and I think Jen's going to join us back.
Rana, thank you so much. That was just such a comprehensive and informative presentation. A couple of things that I really liked was just the fact that you busting some of those myths, especially around the use of imaging and x-rays, and just what you were sort of saying with regards to that they're actually not needed in most circumstances of diagnosing OA. And it was interesting, that study you did where people had no pain and had good function, and yet they showed the imaging showed changes within their knee structure and so on. So that was very informative. The other thing that was great was also about all the detailed information you gave around the different type of exercises. Often people will talk about, yes, you need to exercise, but to give such detailed information and explanations about the type of exercises and so on was really great. And the work that you and your staff have done at your centre in developing these programs, which are freely available to people, is just absolutely marvellous, because we know that, you know, the cost of different programs and gaining advice and so on can be quite prohibitive for some people. So to have these programs freely available, which are backed up by research evidence, is just marvellous. So I'll just remind everyone that everyone will receive a recording of the webinar. So if you're concerned that maybe you've missed some of the information that Rana has outlined, or some of those details where you can find those programs that Rana has developed, you'll be able to check those. You'll get a free copy of the recording that you can view as many times as you like if you need to go back over any of the information. I'll encourage people to ask any questions that if you wish. We've got about 10 minutes for questions, so we'll progress through those. Just a question going back to the very beginning, Rana, someone just asked, why can't the body keep up with the repair processes within the joint? Is that just a factor of age, or does it come down to genetics?
Well, look, it's a great question, and I think if we're able to crack that, get the answer to that question, well, that would help us develop drugs that could, you know, would develop drugs that can treat and reverse osteoarthritis. Unfortunately, we don't really know. I think at the moment it probably is just indicative of what happens as the body gets older and ages. We get wrinkles, things can't keep up, things don't work as well as they did. And so in some cases, it might be that people are, you know, overloading or stressing the body more than what the body's capable of with natural healing. So that's why I think, you know, it's always important to think about what we're doing, you know. And I mean, the obvious thing there is think about, you know, an occupation, for example, where someone's done lots of kneeling, repetitive kneeling, loading day after day. You know, that's a tough ask for the body to be able to continually keep up with that sort of repair. So yeah, we don't know the answer. There's certainly lots of basic scientists out there trying to crack that answer, so that hopefully one day we might have some drugs that can reverse changes within the joints.
Mm-hmm. And there was just a comment from someone who is a massage therapist, and you did mention massage as a possible sort of therapy to help with people with their function and pain levels and so on. So massage is it one of the tools in the toolbox, Rana? That's right?
Yeah, that's right. It's if people remember back to where it's recommended in the guidelines, it's recommended kind of as a second tier adjunctive therapy, if you like. So when we say adjunctive, we mean extra on top of those core therapies. So every person with osteoarthritis should begin with exercise and weight management if that's relevant for their situation. And only if those interventions aren't working well, then yes, start to consider some of these other tools in the box, if you like, and massage might be one of those. Obviously, access and finance, those sorts of things might limit some people, and the research evidence suggests it can be helpful in the short term for symptoms.
Someone's also asked about the benefit of even just the warm spa.
Yes, yep.
Just taking the weight off the joints, and that's beneficial there.
Yeah, absolutely. It's funny. Recommendations. Some people find heat really helpful. Some people find cold helpful. So really, I think one of the things around heat and cold is really, it's one of those things that's really nice. You can try and go with what works for you. I mean, you listen to advice and what others have worked for others, but it's really about you. And if heat and warm spa, and in fact, often a lot of people who get benefit from heat and warm water might choose to combine that with their exercise program and do hydrotherapy or aquatic exercise. So, and then that also has the added benefit of taking the load off the joints with the buoyancy of water. Some people hate the pool, and that's okay. But it's about what suits an individual, and certainly warmth can be very beneficial.
Now, you mentioned hip and knee, and you mentioned hand osteoarthritis in one of your earlier graphs. Someone has asked about what can be done for OA in the spine.
Look, OA in the spine is really very similar. The guidelines for around management of non-specific low back pain, which is really what a lot of back pain is attributed to. There's no specific cause. Often it is, if you had looked at an X-ray, it might look like osteoarthritic changes. It really is many of the same strategies that I've talked about here. Exercise and physical activity, weight management, reducing sedentary behavior, and also changing a lot of, hopefully everybody got the message from my talk. It's really also about the way that you think about the condition, that it's not going to be a crippling, in the vast majority of people, back pain, OA of the hip, of the knee, OA of the back is not going to be, it's not a death sentence. It's not going to be mean that you're going to be disabled in a wheelchair needing surgery in the future. Back pain's the same. It's really about changing the way that you're thinking, having a positive outlook, accepting that there will be, as I said, those fluctuations in symptoms. There will be flare-ups. It happens at the back, at the hip and the knee. Learning how to spot those, learning how to adapt your behaviour to stop those flare-ups from getting to be too severe, and then hopefully smoothing out those pain levels over time. So really the messages for back pain are pretty similar to what the messages that I've talked about here for hips and knees.
And Rana, is there an optimum weight for males and females with osteoarthritis?
No, we certainly haven't got to research that talks about optimal weight, and because obviously optimal weight will differ depending on somebody's height, won't it? Because somebody who's really tall can be and will be heavier than somebody who's really short. But what the evidence, and we're only starting to get more evidence about the benefits of weight loss for osteoarthritis, and as I said, it's all around the knee at the moment. Really, what you want to look at is weight loss of 5 to 10% of your starting weight. Ideally, in the trials that we run with weight loss, we aim for 10% if we can. So it's quite so that's what you need to do. So for a person, weigh yourself, and then set that goal. And then that's the way to go, is to think about it in terms of what ideal amount of weight loss rather than an ideal target weight.
Rana, what advice would you give a person regarding physical activity when the person is experiencing a bit of a flare or maybe more of an acute sort of pain episode?
Yeah, I'd be in those cases, depending on how severe it is. And if you're a regular exerciser, it's okay to have a break and let that settle down. Don't stop your exercise program if you like for a week or so. better if you can to modify it. So it might be that you need to switch to more non-weight bearing exercise. So and most people will usually know the types of activities that flare up their joint, because what flares up my joint might be different to what flares up your joint, for example, Jen. And so you'd want to, if you know that it's prolonged walking or a lot of standing that flares up the joint, well, maybe during those times of flares, maybe that's a time that you'll focus on strengthening exercises that use elastic bands, for example. Maybe that's a time that you would consider going to the pool, for example. So it's thinking about what could I do? What's a type of exercise that I can do that I know doesn't aggravate my joint until it settles down.
And Rana, someone's just asked about the GLAD program. Can you just comment about the GLAD program?
Yep. The GLAD program is, in a way, it kind of pulls together all of the evidence. It's basically a group exercise program that's been designed for people with osteoarthritis, that's usually run by physiotherapists who've been trained in that particular program. And that's certainly a nice package or a way for someone to access an exercise program that's been prescribed for them, and it's done in a group setting. So yes, that is definitely one way that is helpful for people with osteoarthritis if they're not quite sure how to start.
And if someone's experiencing stiffness in their knees when they're asleep or just lying in bed, is that OA? Just with someone sort of commenting when they sort of get up and start moving, it does help. But that stiffness in the knees when they're actually lying still and disturbing their sleep, is that
look, that often is a sign. That's what we would often think is, often it can be at night time. If the key thing is, does it start to ease up once you start moving? So is it that kind of mechanical stiffness? So if you think about it, when you don't use it, when you're sleeping, it stiffens up, but when you get up in the morning, might be a bit creaky, a bit slow to get going, and then it loosens up. Often that can be a sign of osteoarthritis. Some people tend to experience night pain and stiffness in the joint more than others. Other people with osteoarthritis don't have as much of a complaint of that, but that can be a sign, yes.
And the use of orthotics in shoes, is that something that you would recommend?
Look, I've done lots of research on that, and our clinical trials have generally shown that any of the orthotics in the shoes that we've tested, and they tend to be wedged orthotics, which are designed to change the alignment of the knee joint, that they don't offer any benefit over a sham orthotic. So they don't seem to be, clinical trials are not showing that they're helpful, which is why you don't see a broad recommendation to use orthotics in any guidelines, because on average, compared to a sham orthotic, they don't seem to be beneficial. Having said that, there's always some people who find them really helpful. If you're a person perhaps who's always through their lifetime suffered from perhaps, flatter feet and needed an orthotic, because you might be someone who benefits a little bit more, but when we look at the research evidence, it's not particularly compelling. So generally, I'd be usually encouraging people to try other treatments first, and only orthotics if they've kind of exhausted other options.
And you did, I think you covered this, just the best type, but you didn't say there was any best type of exercise, but you did talk about dose and intensity with regards to numbers of repetitions and so on. So there is a question related to that, but I think if the person had the opportunity to view the recording, they'd be able to see that detail that you provided.
Yep.
Now, we're right on 8 p.m. Australian Eastern Standard Time, so we will finish up for this evening. I'd like to thank everyone for joining us this evening, and I'm sure you've gained a lot from watching this webinar this evening, which is great. Rana, thank you so much for not only your wonderful webinar, but your wonderful work. and the fact that all these great programs are freely accessible on your website. So we'll make sure people are quite clear how to access those programs, because they really do sound marvellous. So well done to you. So, and thank
Thanks,
you
Jen.
once again, and wish you and everyone else a very good night. Good night.
Thanks, everyone.